So our next speaker, and after that we'll have the panel, so I hope you're all writing down questions. Our next speaker is Professor Andrea Danese, who's a clinical scientist interested in trauma and trauma-related psychopathology across the life course. After training at the Pavia School of Medicine and the Institute of Psychiatry at King's College London and the London School of Hygiene and Tropical Medicine, he joined the faculty of the Department of Child and Adolescent Psychiatry and the Social, Genetic, and Developmental Psychiatry Center at the Institute of Psychiatry, Psychology, and Neuroscience. He is also a clinical professor at the Yale Child Studies Center. And he leads in London, he leads the Stress and Development Lab. And we're very glad he was willing to come and speak with us. Thank you.
Well, thank you very much, and thank you all for coming back. I know it's the fatal session after lunch, so I hope I will keep you entertained. So, Karistan, as a practitioner, Karistan asked me to share some thoughts today about why practitioners should care about causal inference methods in population mental health. And for background, as Karistan already mentioned, most of the work in my team is really focused in better understanding and mitigating the effects of childhood trauma on psychopathology. And as we try to advance knowledge in this area, we have faced several challenges that I feel are quite common to the challenges that many other practitioners have and are facing. So, for example, we are interested in improving our ability to detect meaningful risks and needs in the population. We're interested in advancing and improving our ability to build models to explain our observations and to use these models to plan helpful actions. We're interested in the ability to select the most relevant, the most helpful actions depending on individual risk and needs. And also, stepping back, we are interested in understanding whether the evidence base really is something we can use to plan and to guide our clinical practice. And I feel causal inference gives us a very elegant framework that help us think more carefully and critically about some of these challenges. So, for example, the focus on measurement and measurement bias in causal inference really prompted us to think more critically about the way we assess trauma in childhood. And that's very important in the area. So when we traditionally talk about trauma, we imagine something that has happened to a child, and then we think about how we can potentially link or test the association between that actual experience to subsequent outcomes. So what we have in mind is what we call an objective experience, right? So we want to try as much as possible to have a measure that captures some event that has happened. The way we do it typically is to rely on third parties or informants. At best, we might have official records that something has happened. And I say at best because, not because this is a perfect measure, but because typically these are the legal standards, for example. So you could think about official court records or child protection records. So these are the sum of lengthy investigations, discussions among experts, and deliberations. And of course, again, it's the legal standard that we use to prosecute perpetrators and protect the victims of these experiences. We can also rely on parental reports in the same way. Most of the research, though, on childhood trauma is actually based on something that is quite different, and we typically rely on adult self-reports of these experiences. And we have long assumed that these two measures are interchangeable, so we can use them interchangeably and draw conclusion from one to the other freely. Thinking about the framework of causal inference, we actually tested the agreement between these two measures. And this just gives you a visual representation. So these two Venn diagrams describe the overlap between prospective and retrospective measures of childhood maltreatment across studies that had the relevant data. And just to give you one example with the broader measure of childhood maltreatment here on the top left, 56 of those with retrospective report didn't have prospective information that were consistent, and 52 of those with prospective measures didn't retrospectively report the experience. So these measures, to a good extent, are different, identify different groups of people, and therefore we might ask, are they both associated similarly, for example, with psychopathology? Well, now a few studies have tested that hypothesis, and we have recently published a meta-analysis of these studies. And what we have seen is that the prospective measure is associated with psychopathology, but that association is quite smaller compared to the association of retrospective measures. Also, if we account for that overlap and we look at the adjusted, if you like, association of prospective measures with the outcome, adjusted for the presence of retrospective measures, that adjusted association is quite a bit and significantly smaller, whereas the association of retrospective measures with psychopathology is still there, right? So putting together this data, the focus of measurement really is highlighting that the way we were measuring and conceptualizing the association between maltreatment and psychopathology is heavily biased by the way we measure childhood maltreatment. And I think this is not just a measurement issue, but brings up a lot of new questions about how we have conceptualized even the processes or the mechanisms that might be underlying those associations. So that's one example. Another example is that the focus of causal inference on confounding really prompted us to examine critically alternative explanations for the presence of an association between childhood trauma and psychopathology. So what I mean by it is that this observed association, of course, could be driven by other factors that in some ways are associated in turn with both childhood trauma and psychopathology. There may be factors that are quite stable over time, and we have heard earlier already some discussions about genetics. So we now have a set of studies that have started testing the role of genetics in this association, and so the testing of genetic confounding of the association between childhood trauma and psychopathology. This is clinically quite interesting because what we observe clinically very often is that we have a very complex psychopathological picture in the context of experiences of childhood trauma and maltreatment. But the way we explain that, so whether we assign a causal role to treatment, maltreatment and trauma, or to other factors, is really important for how we then also plan to deliver treatment, right? You might think about the association between trauma and ADHD, for example, right? Which one do you want to target? Which one do you want to target first, right? Should they both be targeted? So looking at genetic data in this case, sorry, the formatting is a little off, but what you can still see is that there are 3 points across those axes. The yellow one are unadjusted associations. The red points are adjusted association for polygenic risk scores. And we know that polygenic risk scores are a fantastic new resource that we have. This still quite crude resource. So the blue are estimates of the potential genetic impact as a function both of the polygenic risk score and the heritability of those traits. So what this highlights is that the naive or unadjusted association between different forms of adversity and, in this case, internalizing problems in the Alspach study is to a very good extent accounted for by genetic influences. This is true for some of the internalizing problems, some of the externalizing problems, and the findings replicate in a separate independent cohort, right? So that gives us food for thought in terms of not just that abstract question of causation, but where do we put the treatment? How do we target the treatment? And I said this is one example where our potential confounder was fixed in time, right? It's genetics. But we're learning more and more that there may be other confounders in this association that likely change over time. So let me walk you back. We just saw that what was most strongly associated with psychopathology was what we call subjective experience, or the self-report, effectively. So if you like, a memory of what has happened in childhood. Interestingly, I think we need to think about how that memory might shift over time, right? We actually don't know quite well across study how much stability there is in that memory. What we do know is that there is most likely a two-way association between the memory of maltreatment and psychopathology, so that the memory of maltreatment might lead to subsequent psychopathology, but it's also true that depending on current or lifetime psychopathology, our memory, as much as our thinking and our mood, might be negatively biased. And therefore, if we are currently depressed or we have vulnerability for depression, we might have a negative view of how our childhood was, and therefore we might be more likely to report childhood maltreatment. Sadly, we still don't have a design that can adequately test the alternative hypothesis I just mentioned. What we did have, instead of having repeated measure of maltreatment, we had a measure of maltreatment and repeated measures of psychopathology. So what we were initially able to look at was the association between these prospective and retrospective measures of maltreatment with subsequent psychopathology. So those will be the lines in red, while accounting for both concurrent and lifetime psychopathology, right? To at least partly looking at these effects. So these are the unadjusted, naive association, if you like, where we compare the risk of depression in this case in three groups. So those with the objective, subjective, and both measures compared to those with no measure. So again, you see that those with subjective measures have higher rates of psychopathology, particularly those with objective and subjective measures. And we see that the concurrent presence of depression or the lifetime presence of depression don't explain the association with subsequent forms of depression in those with both measures. But they account to the smaller association of the group with subjective measures only and later psychopathology. So thinking about these more complex mechanisms might also help us plan new studies where we account not just for the presence of maltreatment, but concurrent and lifetime measures of psychopathology that would otherwise bias our estimates of group differences. Another example is that the focus of causal inference on heterogeneity prompted us to more critically think about how we allocate interventions after exposure to childhood trauma. And really, at the moment, it mainly prompted us to have a critical overview of our current practices. So instead of discussing trauma, as, for example, DSM would code it, I'm giving you here an example of a related construct, the adverse childhood experiences. So this is a set of 10 experiences that we usually count and accumulate together to have an overall cumulative score. So what you see here on the x-axis is increasing levels of reported adverse childhood experiences. And what you see, and this is a very replicated and reliable finding in the literature, is that with increasing levels of ACEs, we have increasing levels of psychopathology in the population. What we do typically to allocate resources based on the framework that has been built around the ACE screening is that we would call those at the high end of the distribution, typically those with 4 or more ACEs, we identify those as being at risk, and then we allocate resources for interventions and further assessment and treatment to them. Of course, if we take that approach based on this distribution, we have a set of issues. One being that a good proportion of those that we identify at risk will actually not develop the outcome. Therefore, they will be false positives. And in this case, potentially providing intervention will not only be expensive, but maybe even detrimental. We just heard from Carison that providing interventions, even psychological interventions, can be detrimental. The other side of the coin, of course, is that because of the distribution of these ACEs in the population, most people will have lower ACEs from 0 to 3, for example, and most of the cases or the outcomes in the populations will be in this group. So we will have a significant amount also of false negatives. So these are people that we didn't recognize as being at risk, but should have had interventions, right? So what we are now trying to do, thanks to that critical question about heterogeneity in the population, is trying to really understand how we can best address, measure, and build on this heterogeneity to identify vulnerability and resilience factor, and therefore through them plan better ways of delivering interventions in the population. The final example I wanted to make is the one about the focus of selection in population mental health and in causal inference. And that really has prompted us to ask how much the evidence-based is relying on samples that are representative to the samples that we work on clinically, for example. And that's really important in this area of childhood trauma. The reason for it is that if we, for example, focus on our research simply on clinical cases, well, we will miss most of the cases of children and adolescents who do have traumatic experiences. So these are data from a population representative study in the UK, the ERISC longitudinal study. And what you see is that only 20% of those participants at age 18 reporting lifetime trauma, only 20% of them sought support from a health practitioner, and 10% sought support from a mental health practitioner. So most of them were never seen clinically. And that really highlights to me the need to study mental health at the population level rather or in conjunctions with the study at the clinical level. And things are not much better for mental health. We heard it already this morning. Most people with mental health problems, even severe and distressing mental health problems such as PTSD, again, don't seek support from health practitioners. So if we want to study associations such as those of childhood trauma and psychopathology, clearly we cannot limit ourselves to clinical designs, but we need to think about population representative samples. And this is simply thinking about those measures, but as we have heard repeatedly, both in previous talks and in this one, what we do want typically is a longitudinal design. And there is another challenge there, which is that in longitudinal design, we often have, of course, attrition. In population studies, we often have quite high levels of attrition, and there is a concern actually that the level of attrition are increasing even over time. But most importantly, not just the fraction of people who don't take part in the study, but the relative distribution, right? So what we call differential attrition. And this is just an example, not from our data, but from what is likely to happen in the population. And what you see is that typically at follow-up, you have a much smaller proportion of individuals at risk. And of course, you can imagine if that proportion changes and there is such a bias in changes longitudinally, then the conclusions we can draw are limited in that way. So again, concluding, practitioners should be very interested in causal inference for all sorts of reasons that I think are very dear to our daily activities. and I'm really glad to be here and share some reflection on causal inference in practice. Thank you very much.